Welcome to New York Bio's virtual breakfast series, a digital program created in 2020 featuring fireside chats with leaders from across the healthcare spectrum. This week's episode featured a discussion with Shunichi Nick Homma of Columbia University and Jason Johnson of Moses Singer, talking about the future of telehealth.
Great. All right, everybody. Welcome to another edition of the New York Bio virtual breakfast series. We are thrilled that today we are going to be talking telehealth, something that probably most of us have experienced over the last year and maybe never before the last 12 months. In fact, my son has a dermatologist appointment at 7:15 tonight. He will be right here, exactly where I am, visiting his dermatologist. But let's get started with the usual things. Thank you to Moses and Singer and Jason Johnson, one of our speakers with Moses and Singer today, as well as Dr. Nick Homma. We're going to be talking and really learning about the evolution and how rapidly telehealth has evolved, certainly in the public usage over the past 12 plus months. As always, housekeeping. Please put your questions in the Q&A box or in the chat, and Derek and I will monitor those as they come in and be able to ask those questions of our guests. So with that, we're very much looking forward to our discussion, and I will kick it over to Derek to do a more thorough introduction of our guests today. Thanks so much.
All right, thanks, Jennifer, and good morning to both of you, Jason and Nick. It's great to have you here. Like Jennifer said, telehealth has been just completely escalated over the past year. And we're excited to talk to you because there's a lot of parameters to think about. How do we think about this from the standpoint of care delivery? And certainly, how do we look at what's going to happen from a legal standpoint? Because those were some of the major barriers in front of telehealth's wider acceptance. So with that, why don't we I'll have you do a quick intro of yourselves. Let us know a little bit about how you got to where you are, and then we'll kick back into discussion. So Jason, why don't we start with you?
Sure. Thanks, Nick and Jennifer. So Jason Johnson, I'm a partner at Moses and Singer in the healthcare, data privacy, cybersecurity, and IT groups. I came to law kind of circuitously. So I started out in the lab. I did benchtop research for about 6 years before I went back to law school. But for me, I actually kind of got into telehealth really early. I was an EMT and firefighter for a couple of years down in North Carolina, and so one of the hospitals we worked with is Duke University, and they started this pilot program where for certain types of injuries like heart attacks and certain types of traumas, you actually would connect with the ER directly, on your way in. Because Durham it's a little bit rural, so sometimes you're looking at half an hour to 45 minutes from the time the incident occurs to the time the person gets to the ER. And so this pilot program was meant to try to help assist in stabilization and minimizing the continuation of the injury. And it was really neat, really interesting. Sending EKGs over and talking with the ER docs. A lot of this was basic stuff, but I think at the end of the day, statistically, they showed that it actually, increased survivability rates, or at least decreased injury rates. And so,
Yep.
So that was a really, I guess, neat introduction into that world. And so after that, I went to law school, and I was a patent litigator in the pharma space for about 11 years before I came over to Moses and Singer. And since I've been at Moses and Singer, it's been really focused on the healthcare regulatory side of things and the data privacy side. So I'm excited to talk about, where telehealth came from and where I think it's going today.
That sounds great. All right, Nick, over to you.
Yeah, hi everyone. Good to be here. My name is Nick Homma. I'm currently the Chief Medical Officer at Columbia University Irving Medical Center. And I'm a cardiologist by training. I'm a Deputy Chief of Cardiology here. And I also head up currently Digital Health Executive Committee. It's been quite a journey for us. We spent over a year preparing for effectively implemented in February. And thank God it's got implemented, because without that, we couldn't have faced telehealth. And then that's when COVID started simultaneously, and they were looking for masks, and at the same time trying to buy iPads for telehealth. So it's been an exciting journey, but as we stabilize, we begin to see this as opportunity, really, to expand our reaches to offer what we can offer specialty care to many people, not only around the country, but potentially around the world. And we see, in a way, telehealth as a very important opportunity for us to change the way we do medicine. And telehealth really is one part of digital health technology development. There are so many things happening around it. So the important point for us is to make sure we integrate many things that are happening around us. Telehealth is just one of them, to really improve the healthcare delivery system that we have. So I'm very, in a way, it's one of the very few good things that might have resulted from COVID.
I think one of the things that we think about a lot is it brings up the realization that people need care. I think in a lot of ways, healthcare is this abstract concept in a lot of ways to people that don't interface with it every day. And what this did really is brought up the prospect of you may need to see a doctor more often. You may need to see it. It brought it into focus for everyone because everyone needed to access the system in one way or another. And perhaps at least a little bit of that appreciation made everyone realize that when there's this big rush, it doesn't always work as efficiently as we'd like it to, and there are better ways to do it. So hopefully there's a little bit of motivation to make things a little bit better, because also, as we've seen, there's challenges with access, and some people have much more difficult time getting the care that they need. So, Jason, why don't you give us a little bit of background, tell us kind of the telehealth story, if you will, and a little bit about what some of the challenges were that we were facing pre-COVID.
Yeah, so I mean, I think there are a couple legal and regulatory challenges, and also some market-related challenges that went into what telehealth was going through initially. And so pre-COVID, at the state level, right? States are the ones that license physicians. And so if I'm practicing in New Jersey, I have to be licensed in New Jersey. And so I can't go see patients in New York unless I'm licensed in New York. So from the state perspective, it really sort of compartmentalized who you could see and who you could talk to, unless you're going to get multiple licensures, right? So that in and of itself created sort of this compact system for the telehealth, right? And then obviously on the data privacy side, HIPAA, right? So you have to be HIPAA compliant if you're going to have access to these patients and use these platforms. And so not everyone is ready to be HIPAA compliant and can create a platform that's HIPAA compliant, and so, access to those types of tools is also a little bit more limited, because that's a pretty expensive proposition. And from a business perspective, right, if you look at the numbers that CMS put out, I think that pre-COVID, there were about 1,300-ish telehealth visits per week that were happening. Okay. And maybe 13,000, I may have that number wrong, but during COVID, there were 1.7 million per week, right? And so
is that countrywide?
That's countrywide, right? And that's from CMS from last summer. And so, I mean, if you think about, from a business perspective, am I going to create a model that sees a little bit of money from 13,000 people versus 1.7 million? You can see why there was a huge expansion of platforms that kind of boomed from that, right? Because now there's access. And so what happened during COVID was that the states relaxed a lot of the rules when it came to licensure and seeing patients, right? And to be honest, Derek, going to your point that you raised earlier about, we don't really see, kind of the healthcare side of this, and I'm sure Nick can talk to this, because I've seen it through my wife, who's a physician. I mean, there were people that didn't see a physician for 6 or 8 months during COVID. And, my wife was saying that there are things that she learned about in med school that you just never see, that you were seeing multiple versions of these things, because, people just weren't going to get the care. And so things were, progressing as they shouldn't normally, because usually you'd be able to go see someone. And so, and I'm sure in the rural health care setting, this is already, more prevalent. I mean, that's probably why they're in the medical textbooks, right? But I think, those combinations of factors, the access and the fact that you really did see people suffering by not being able to get access, I think that's kind of what changed the tenor of this. And then on the market side, what you saw was pre-COVID, there were a lot of services that CMS just didn't pay for from a televisit perspective, and there wasn't payment parity. Right. So you didn't get reimbursed the same amount if you saw someone virtually versus seeing someone in person. not only that, but CMS currently still has, and this is going to have to be fixed by Congress, but if I wanted to do a telehealth visit that was going to be reimbursed by CMS, I had to literally go to a physician's office and link from the physician's office to go telehealth with another physician. So that's the way the CMS rules work. Because the law was really written for rural health, right? So it's really focused on the rural health aspect of this. And so that has been lifted during this part as well. And, CMS has actually increased the total number of services that it reimburses for. So it's not only medical care, but mental health care, occupational therapy and physical therapy visits. So, as Nick was saying, this is not just, I got something on my arm. What is it? What's wrong, doctor? This is the integrated healthcare part of it, right? And so what's going to have to happen though is all of this is basically just executive orders or emergency actions that say we're going to lift the status quo. And so moving forward, all that is going to have to be, somehow changed legally in the laws or the regulations. Otherwise, we're going to go back to where we started. But luckily, there's a push right across the country. Some states like Arizona, for example, they have a bill pending where they're going to put into place all of the COVID exceptions that occur. So they're going to allow licensed physicians, if this passes, that are licensed in, say, California or New Mexico to see patients that are in Arizona, right? They're going to create requirements for payment parity, and they're going to reimburse along the same lines. And so usually when CMS pays, private payers follow. So, hopefully that's what the model is going to be here, but at least CMS is expanding the scope of services that it's paying for. So, I think that's going to stick. So
Nick, talk to us. So Jason set the stage as sort of what the national regulatory landscape looks like. Talk to us about New York, and specifically, like you said, you were in a better position, right? The hospital was, because you all had implemented, your crystal ball was clearly working if you implemented something in February of last year that would be more access to digital. Talk to us about where you all are and what you see happening with New York Presbyterian.
Yeah, so February, March were really crazy times, as Derek mentioned and Jason mentioned. The number of telehealth we were doing about in February 10 a day, and that's then increased dramatically to over 2,000 a day. So how do you do that? It's like 0 to 60 in 2 seconds. And how do you do that? So we had to suddenly train our physicians. We have to buy many iPads, honor the market on iPad and configure each one of these, create pathways in our Epic EMR to enable this. This, again, as I was saying, was happening at the same time that COVID number was really increasing. And at one point, out of NYPH's 2,600 beds, 2,400 were COVID patients. So all the clinics were closed. PPEs were a problem. As you remember, you saw in the newspapers, people really complaining about no PPEs. So it was really, I don't want to say crazy, but it was sort of stressful times for all of us. But
I think it's fair to say crazy. I think this is kind of a hopefully once in a lifetime event. We can go with crazy. We'll allow it.
Okay, well, I appreciate that. Thank you. And then we realized that, hey, you know what? We got to look ahead of this. What's going to happen when PHE is over? So at that point, we started to investigate each state's licensure issues. So that we understand. Like Florida, you can get for $55 telehealth license. New Jersey, you can register. You have to register. We started to actually have a documentation and updating of what each state is doing. As you know, PHE was just extended on April 21st for 3 months. It's called for 3 months increments. And we expect this to last to the end of that year. What's going to happen after that? So we decided we need to have a broad vision about where we're going with our medicine. We're going to go national, potentially international. That means we have to be licensed in other states. Therefore, we have subsidized a significant portion of licensing fee for specialty physicians to be able to continue telehealth
Right.
after PHE is over. And also, there's an issue of a HIPAA compliant platform to use. Good thing is many systems are on Epic, so we can actually have EMR transparency in terms of getting information about patients. But in order to interact with patients who may not be on Epic, what do we do? Well, there are different platforms we can potentially use. So we are talking to different vendors to figure out how we might do this in the states that we may actually not have a licensing, because it's very difficult to get licensing in all 50 states for all our physicians. Because each state's license actually costs money, and we're talking $700-800. So it's a significant investment. So we are judiciously thinking about how to proceed for after PHE period, because that's when I think we need to be ready, and that's when we can figure out how to conduct and implement our vision in digital health. We're also working obviously with New York State. Some of us participate in the advisory committee to advise the state on what they should be thinking about. And one of the things they should be thinking about, and we thought about, is standardization of telehealth care. And if you think about it, your doctor, the dermatologist that your son seeing tonight, may not be used for telehealth for the same indication as another dermatologist.
Right.
So there isn't a standardization on that. If I am a payer, I would want to know why you're using this technology versus another one, and how you're using it. So standardization is necessary. So we actually even established recommended standardized way of doing telehealth for what's indication for over 30 specialties in our institution, which we have distributed to our what we call telehealth champions, as well as Cornell and other NYPH hospitals.
Have you looked at, I mean, do you have any data on where your NYPH patients have gone, right? So if you're thinking about sort of triaging, you can't go national necessarily for every physician that wants to do specialty and to make telehealth available to their patient load. Does it make sense to look at sort of where your patients are now as far as concentrations? You mentioned Florida, it's relatively inexpensive to get the telehealth license. Is that a way to start the process?
Well, obviously, you like to make sure you cover the area where the telehealth is most heavily used. So we obviously surveyed where our patients are from, so we know where they are from. But then again, treating patients with common illness, which that becomes a local issue. Then there is a sub-specialty issue. For example, if someone wants to access a specialist to treat a very specific type of brain tumor, now this is a 50-state issue. That's a different issue. So the telehealth becomes widely applicable for offering subspecialty services to those who are unable to access it before. So that's the way we think about it. And then for the local telehealth, that's purely convenience and access issue. Then for the subspecialty, it becomes offering the niche product to those who couldn't get it before. So there are two ways to think around it. Yeah, that's how we think about that.
Yeah, if I could just add just a little bit to that, right? So I mean, telehealth did exist before COVID, right? And there were companies that specialized in offering a suite of physicians assistants, RNs that were licensed at the local level, right? So from a partnership perspective, you could hire local physicians. I think the difference now is sort of integrating it into your own EHR and your own system, and as Nick mentioned, your own standards, right? And so it's no longer just I need a doctor in Florida that can do this, right? You want someone that's going to be part of your your like hospital system that's going to treat patients the way you want them to be treated, right? Because really, at the end of the day, hospitals are still businesses, right? And so you need to put out the appropriate product that treats people in the appropriate way. And so I'm curious to see how that's going to play out, right? Because as Nick mentioned, there are obligations across the state, both from a financial perspective, but also from a legal perspective, right? New York is actually one of the hardest states to practice in on this telemedicine front, not because of the licensure, but there's a state law that requires the physician and the patient to actually enter into a real relationship, right? So if I just want to go see a doctor, as a one-off or something, technically speaking, that's not allowed by law, right? And so what you've got is you have to deal now with this, some of these additional state laws and regulations. So it's not just as simple as let me get licensed in a lot of cases, particularly New York. And so I think that's going to be, interesting to see how that ecosystem evolves, because there are already a lot of trained licensed physicians kind of around the country, and companies that are offering them. And then the other thing I wanted to mention was the platform issue, because this is also very important. Like, as I mentioned before, there weren't a lot of, I would say, telehealth platforms that were truly HIPAA compliant before, just because there didn't seem to be too much of a need. But during the pandemic, there was obviously a need for more of those platforms. And so what OCR did was that they said, look, we're not going to enforce some of this HIPAA requirements for certain types of platforms, and we're going to allow that to slide for the time being. And you don't need to necessarily have a business associate agreement with these folks. And so they gave out a list of certain types of platforms that would be able to be used for these telehealth visits, right? So things like Zoom, for example, versus things like, TikTok, publicly facing types of platforms. But because I mean, look, people were looking for any type of like video access, right? And so, they allowed these companies to operate as the platform. But again, going forward, there's going to have to be some sort of standardization. Like HIPAA is going to be enforced again. And as long as you're, going to be acting in good faith, and there's going to have to be business associate agreements. And so I think the other thing you're going to see is more of these platforms pop up that are going to be HIPAA compliant, but that's a vetting issue you want to make sure you really look at. And then these formalization of the arrangements through business associate agreements. So I think that's the other side of this, is that the technology side is booming as well, as people realize that there's going to be a lot of need for this stuff.
Well, there's a good question here too that builds off something that Nick was saying. I was just going to ask this, and the question is, post-pandemic, which sectors are expected to survive the expiration of the mandate? And I had thought about this too, because Nick was talking about specialization, right? So when you think about specialization, does that make it harder from a legal standpoint to really kind of wrap all of this into an appropriate legal structure, right? So you had said before, some of this may have to be done through, executive action and that kind of thing. But, if we don't have something that's going to, stay from administration to administration, aren't we going to just be playing this legal yo-yo game, hopefully, every 4 years? Is that really a possibility?
I mean, I think so. And again, because there's such an interplay here between state and federal, right? I mean, states still govern who can practice in their states. They still license physicians. And so whatever laws and regulations are in place for that are going to govern, no matter if CMS is going to pay, twice the amount as like an inpatient visit. So, I mean, you still have to meet those state requirements. And so I think, that's going to be the interesting interplay, right? Because right now there's a lot of talk at the state level about changing licensure requirements, right? But other than Arizona, Washington, and I think a few other states, not many states have actually, have draft legislations that actually change what the status quo is. And so, I think as the year moves on, and as we, get into next year, and the public health emergency is lifted, I think that's going to be really going to start dictating a lot of this stuff. And so I know that from a patient perspective, there's a huge push to change these, legal and regulatory barriers to allow me as a patient to, see whoever, particularly in rural communities, right? I mean, these folks have been the focus of a lot of the, CMS rules and other rules on access, and rightfully so, right? I mean, there are places where you could probably be 100 or so more miles away from any type of, true physician. And so telehealth access is a game changer for these folks. I mean, you're really thinking about, changing lifestyles and, expanding, your health, right? And so, I think you may see more of this in the rural communities first, this push, because, for them to be able to go see a specialist at Presbyterian is better than seeing their local, PA who has never seen this stuff before and barely knows what to do. And so, but I think, it's really going to be state driven, a lot of this stuff, at the end of the day, because of the licensure. And then, as Nick was saying, hospitals are going to follow. There are some states where you can, license yourself. There are some states where there's a plethora of doctors already licensed that you can, bring into your network. So, yeah, I think that's what's going to happen is the states are going to try to drive this.
Right. So Nick, if we think about the delivery of medical care as, say, a product, right, and the ability to kind of deliver that product to everyone, whether you're in rural settings or whether you're in, even in urban settings where people have more difficulty getting to care. Do you foresee us having this interplay between telehealth services and local care? How do you see that playing out between the initial telehealth interactions and really with the need for eventual in-person services?
The way I think about it is that specialty care is something one progresses to, rather than you actually, you don't, most people don't make an appointment with a transplant surgeon, right?
Mm-hmm.
And
difficult area to do electronically.
Or if you have no reason to get a heart transplant. So it has to be, these are basically, to me, the resource that has to be judiciously used, otherwise it causes confusion. So there has to be a local input that drives to specialty care up the chain. And that has to be arranged appropriately. And this actually is an interesting issue, and we are designing our own self-scheduling modules for our physicians. For certain physicians, you don't want people to self-schedule because they may not need such people in the first place. So to me, it's similar to that. So there needs to be a judicious way of referring upstream to appropriate specialists. And I think that's one of the things that we are missing at this point, and that we need to have sort of a local control so that a judicious upstream referral can be made. And on the other side, after the patient is taken care, that at the local level, patient is followed appropriately also. So that's how I think about this.
Okay. Yeah, that's really interesting. I mean, I think there's, when we think beyond COVID, I hope people kind of put on their innovation hats and say, okay, is there a way to make this specialty better? Is there a way to make this more efficient? Is there a way to make this area more efficient? And, ideally we'll see kind of certain areas lead the way, and, and patient outcomes improve. And then we get to, kind of this generalized, thing where, telehealth becomes, in this area, this is how we do it. This is how we're seeing this happen with patients. So, you mentioned international, right? I mean, do we have the possibility of a world where, we actually see things, visits from outside the country, or do we see this stretching beyond the border, beyond a country's borders, whether it's our country, whether it's other countries?
Well, we often do get patients from outside the country who fly over for consultations, but that then becomes local consultations. So that's fine. And then at the same time, well, how about if you don't have to fly over and just can talk to someone? Why do I spend 17 hours flying from Singapore? That's kind of far. So wouldn't it be easier if we just chat? That's where we like to go. But there are regulations. I'm sure Jason can speak to this, but there are tons of regulations around the world. That's a problem. So there are ways to think around it. physician to physician opinion exchange, and there are different ways to get around it. But at the same time, if you think about it, why can't someone in any country, Singapore, say, if they want the Starbucks coffee, why can't they get the same Starbucks coffee around as you might get someplace else? And why do I have to fly over to the US to drink one? That's kind of crazy. So
if they can make, if there's Starbucks espresso in Singapore, why can't there be a Columbia dermatologist in Singapore as well? So Jason, that should be pretty straightforward, right? There's no legal issues there.
Yeah, none. Yeah, just talk to whoever you want to. No, I mean, I think, I see sort of two, bigger issues. One is an unfortunate one, and one I think is a practical one. So the practical one is just data privacy, right? So anytime I work with someone in another country, I need to probably abide by that country's rules related to privacy. And so, GDPR, I'm sure you guys are all aware of the European, and now in California with CCPA. And so, I think, again, practically going back to, the protection of data and the access, I think data privacy is going to be an issue for that. But that's you can get around that, right? I mean, you can create platforms and systems that are compliant. So it may just cost a little bit more, but I think at the end of the day, that's an issue that you can deal with. I think the other issue is the unfortunate one, which is, malpractice and injury, right? I mean, if I'm seeing a physician from New York and I'm in Singapore and I get bad advice, what's my recourse? And I think that's an unfortunate practical side of this. And, no one wants to talk about it, but I think that's also a bit of a barrier as part of this is that, look, this stuff happens all the time, right? People fly to the US and they get surgeries and they get taken care of, and vice versa. Physicians fly over to, countries overseas and do the same thing. And so, I mean, the system already exists, but, I think that is going to be maybe something at a higher level that will have to be discussed if telehealth kind of opens everything up. But I think really it's just setting your systems up on the data privacy side, which is going to be the real practical thing you're going to have to deal with.
Yeah. So this is a really good question, and I'm a little guilty of this in this conversation. And the question is, tech loves efficient, but don't we seek a cluster of other values, such as having the patient feel they were truly cared for, or an emotional connection that's really important for healing and life? Are there ways to think of this beyond efficiency, so to speak, in terms of delivery of care or how the patient feels about their care or the actual level of connectedness? So I think I've used efficiency a couple times in this conversation, but really, can we think about that? Can we think about kind of the emotional part of healthcare and that level of connection?
So
Nick, I'll give this one to you.
Oh yeah.
All right. So in terms of an emotional level of connection, I guess I'll preface this by saying that the highest utilization by specialty of telehealth is psychiatry now. 95% of psychiatry is now through telehealth. And so it seems to be, first, being on the screen seems to be able to provide the type of care that they need. And I think the ability to actually see someone more easily also supports the patient in a much better way.
Yeah.
So to your point, Derek, I think more frequent contact doesn't have to be from physicians, but from the fact that someone cares about you, someone's looking after you is very important. And, the patient, I've felt that way. And I think being able to connect with the patient, check on them, how you doing. Those are important aspects of telehealth that we can incorporate, not just for physician to talk to the patient, but having our assistants, PAs, and nurses actually contact them on a frequent basis. So they can be a part of, shall I say, a telehealth ecosystem. I think that we need to think about going in the future.
Yeah. I would agree. I think if you had asked me before the pandemic about the ability to, connect with people in a virtual setting like this, I would have probably said, oh, I don't think there's any way it's going to ever match in person. And, while it may not be 100%, I've actually really felt that it's a decent substitute. And I think one of the things that we may see here is the ability to kind of overcome preconceived notions of, how to make a connection or what a connection looks like, or really preconceived notions of what people think about telehealth and telehealth interactions can be. It's one of those areas where until you actually start doing it, you're kind of victim to your own biases of what you think it might be like.
Yeah, if I can add a couple points to that. So I think,
yeah,
at the legal level, right, there's a couple of acts that are before Congress. One is called the TREATS Act, which is really focused on opioid addiction and expanding the way that folks that have these, addictions can actually meet with and get prescriptions and talk with counselors about this, right? And so I think, that's one part of it, which is expanding the types of services that go through mental health. And then the Telehealth Expansion Act is the same thing. So it's really, allowing for reimbursement for PAs and occupational therapists and physical therapists. And so, RN. So again, you're expanding the universe of who a patient can see as part of their sort of integrated healthcare solution. But I think to the bigger point, there's a big, I think, change going on in healthcare right now. So in the first quarter of this year, was the biggest amount of investment in digital health in a quarter that they've ever seen. And coupled with now in April, where patients really have to have access to all of their results and information basically immediately, and people can take their entire EHR and put it on their phone, right, or a cloud. I mean, patients are able to move around more easily than in the past, and really talk with and see different physicians, RNs, whoever they think they need to deal with their own care, right? And I think what that's going to lead to is what Nick was saying, which is that what's missing from that system is, like, it's great, I've got all these digital health apps that are helping me, manage all this stuff. I've got 3 or 4 different folks that I'm talking to, but who's the person that's overseeing the individual, right? So someone should be there to, like, be the quarterback, so to speak, that's you're really looking at everything. Because look, technology is great, a lot of shiny tools, feels good, but if unless someone is, like, kind of looking at the bigger picture, I think you lose a little bit there. From the old school, right? We used to go see your, primary care doctor in your local neighborhood every year, and they would know everything that's going on. So I think trying to keep that piece is going to be important. But I mean, the movement, the amount of information, and the ability for people to, see whoever they want to, if telehealth expands that, I think that quarterback is going to be really the key to make sure things just don't get missed.
And one thing that Nick, when he was talking about the care of the patient, right, and how psychiatry has definitely shifted. I have a friend who's a psychiatrist, and I think all of her patients right now, right, and she has no plans really, unless the patient wants to go back into the office. But as far as sort of equity and availability, it has the potential to be convenient, even if you're in the same location. But for those scattered, across, I mean, take New York State. It can take you 10 hours to drive from one end to the other, right? That you may still be within the state of New York and not be convenient to Columbia. And so then it also has the ability to make access more equitable to the specialist, as Nick was talking about, and to be able to, to let them practice and see patients in ways that they wouldn't have been able to do. So talk to us, maybe, Nick, as far as first what you're seeing within your in the hospital and the patients, about sort of, does it have the potential to expand equitable access to different patients?
Yes, let me answer that, and I'll go back about to Jason Derek's issue about the innovation. So first, the equity issue. Well, certainly it makes the subspecialists available on ready fashion, as long as it's calculated up from appropriate channels. So that's what we want to do, not only in New York State, rural areas. So we are talking to some of the more rurally positioned health systems to actually have our physicians available on a regular basis.
Right.
So that's one. That we can do in New York State, and obviously we like to do that out of state, and that's where the licensing issue becomes sort of a barrier, and the extension that is due it's overseas, then the other issues that come up. But I think I'm glad we're talking about these topics, because unless we start talking about these issues, and weigh pros and cons, we never be able to reach there. So I think I see this chipping away at the little, sort of a wall. And at the end of the day, eventually we'll make it fall and make sure that we can make medicine available to many people. In terms of innovations, issue that we brought up, there's so many innovations coming up. And, I always think, form should follow function, and not that you create function and try to make it fit into what the healthcare system, which is a form. So I always think it's very important that inventors think about what's really needed rather than make something and try to somehow fit it into the ecosystem of the healthcare. So I do think dialogue amongst patients, physicians, and inventors is so important to make sure that we make something that's really useful and not something that may not be useful, which does happen a lot. So I wanted to just mention that.
Well, I think you hit on one of probably the biggest advantages of New York, right? We have this confluence of engineers, of entrepreneurs, of capitals, and certainly in my, I suppose, humble opinion, probably the best, network of medical centers in the country, if not the world, right? So we have really just about the best breeding ground for this stuff to take off. And I know Columbia very well because my wife is at Columbia, and I've obviously known Orr and his team for ages, but they do an exceptional job of really getting the level of access and integration between kind of scientists, engineers, and people to help drive those things into the market. And we've seen really great things happen in New York City over, I would say, the past decade that makes me really, really confident for what we're going to see next. So there was something, Jason, that you said before that made me think about, I think a big parameter here. You talked about all of the different apps and all of the different options that we're going to have. And I think it would be interesting to talk a little bit about trust in terms of the patient and the medical system, right? It's one thing to kind of Google a telehealth app and find it from there. It's a whole other thing to have your telehealth experience come organically from either your trusted doctor or from the place from the hospital that you visit. So we could talk a little bit about how this uptake happens, how say the nurses, the practitioners, the people that actually are introducing people to these digital technologies kind of serve as the first introduction to here's the new way that we're going to interact with the care system.
Yeah, I mean, I think what Nick said is probably the way to start this, which is, I don't wake up one morning and say, man, my heart hurts. I think I need to talk with, a heart surgeon, right? So what you do is you're gonna go to, your primary, right? Your internist and say, hey, I've got this heart problem. What should I do? And so, I mean, I think again, part of this goes back to trust comes from, the preventative care side of this, at least for me personally, right? I mean, that's the way I look at it. Like I've been lucky enough to find a good primary care physician where I trust him, right? And so he knows me, and if he recommends something, then I'm going to follow it. So I think first and foremost, just those, sort of baseline patient connections are really important. And the interaction itself, I think making sure that, and again, this goes back to what Nick said, the inpatient visit should be just like the telehealth visit, right? I should get the same type of service. I should get the same type of, interaction with my physician. It shouldn't feel like I'm having a FaceTime where, he or she is like looking off in the distance and I'm like barely getting any of their time because they're trying to multitask, right? Because, in this Zoom culture, I think we all know when people are trying to multitask, right? And so, as a patient, I don't want to feel that as part of this. And so I think those sort of baseline interactions, and even when you go to the subspecialty side, it's the same thing, right? It's just making people feel comfortable that they can trust the advice because you're being listened to and heard. And I know it sounds pretty simple and basic, like, be a good doctor, but I think that's what it comes down to. I mean, why am I gonna spend 10 minutes on a Zoom and feel like I got nothing accomplished and I'm right where I started when I called, right? If I don't have my problem resolved. So I think that's where you build trust, is built out from there. And I think Nick's right. The standardization across the board with how this has to work. I mean, you should be able to get the same Starbucks if you go to, Singapore or, Upper East Side, right? I mean, it's just, I should be able to get the same type of, cardiology support if I go in person versus telehealth.
Yeah.
Well,
so Nick, do you see,
actually,
go ahead, Jennifer.
Yeah, we had a comment that I actually hadn't thought about, which is great. It said, the comment from the audience said, in a telehealth visit, the clinician is staring at the screen and thus the camera because they are, looking at the EMR. But as a result, the patient can then see the clinician's face. But at an in-person visit, the clinician is often staring at the screen, many times with their back to the patient. And actually, so there are definitely, I think, settings where a telehealth visit may feel more connected because you're looking and you're seeing expressions and having that conversation.
I think that's a very good point. It's very difficult to, when you're seeing someone in person, look at the screen at the patient simultaneously. It's basically impossible unless you have eyes in different places, which most people don't. So, so in that sense, it makes tremendous sense. And to some of the points made, I think patient experience is very important. So we need to start reviewing. We have these press gaining reports for 4-star, 5, whatever, right? So that's some of the things we will be doing, getting the telehealth feedback. So we know who delivers telehealth well, who doesn't, and I think we can learn from each other. And more important is really the outcome. Does this really improve the outcome of hard measures? Disease, probably morbidity, mortality through the use of this technology. So we need to start looking at this in a fairly rigorous way. Otherwise, it becomes a proliferation without understanding the cost-benefit ratio, which becomes very important going forward in any healthcare. So that's some of the things we are thinking about. And lastly, about first you see a primary care physician, then you need a specialist. Well, we need to have a fairly seamless way to connect from primary care telehealth to specialty care telehealth. So that's another topic. So it's sort of a vertical integration of these modalities is needed. And if you need a specialist, hey, do I just need to see one specialist, or maybe it overlaps with 2 or 3 specialists? Then what do? Do you make them sequentially? Or how about if you can see them all at the same time? Wouldn't that be more convenient? So there are many sort of innovations that needs to be and can be built in to make the experience a lot more efficient going forward. So there are many other things to do now.
Do you see us getting to? I'm sorry. Do you see us getting to the point where we may actually have data and some testing actually start to kind of break that wall into the home as well? I know there are ways of doing EKGs remotely and a few other kind of remote testing type of things. Do you see that becoming a little more standard rather than having the in-person visit where the first thing they do is order kind of the standard battery of tests? Do you see any way of kind of doing that in a remote fashion as well?
Well, there are devices already available to do some of those. There are little scopes you can put into your mouth or ear and so forth and deliver the images, and good for kids and so forth. And there are devices to actually listen to the heart. But these are not always easy to use at this point. But I think they'll become easier to use and cheaper. That's very important because well, what are you going to do? You have to buy this, or do you have to go get it? And what do you do after you use it? So I do foresee a future in which more easily usable devices, accurate, obviously have to go through clinical testing to make sure that it works and its fidelity is high, that it will replace more and more the need to actually drive 2 hours to see a doctor and pay $50 for parking and wait in a crowded waiting area. I think those are totally unnecessary.
And So last spring, like many Americans, we were worried about accessing care, right? Given COVID, and particularly in New York. So my husband bought a Taito Care, right? Which is like what, so it's basically a kit, for those that don't know, it's a kit that has the sort of the diagnostic tools Nick was talking about, that we would hold up to our heart and look, hold in our ears. And it's basically a camera that the physician can then see. Apparently we have no heartbeat because we could not use it very well. But I think, yes, that's it. This is a real world example, right? It's figuring out how to use
Virtually
it.
dead, not clinically dead, right?
Yes, precisely.
Yeah.
I'm glad that he didn't instruct you to use a defibrillator. That's
Yeah, really. But I think it's motivation too, right? The patient needs to be motivated to figure out how to use those tools and how to work with their physician on incorporating that into their care.
Yeah, well, there are devices, for example, implanted devices that measure the pressure in the heart that we use extensively now, which prevents readmission for patients with significant heart failure. Those are already being used, but now we're talking more generally applicable tools. And for the inventors on the call today, I hope you're listening to this so that we can develop something that's can be used widely to really reduce the number of visits needed in the future.
Yeah.
So Jason, this one I'll go over to you. We have another good question. So how do we think that payers are going to address in network versus out of network stuff for specialists? This is complicated.
Yeah, I was actually going to go back to this because all this stuff is great to talk about, being at home with your Google device, getting your heart rate, taken or whatever, but who's going to pay for that, and who's going to pay for the doctor's time, right? And I think these are really difficult questions. And so, again, CMS is started the charge right now by expanding what it will pay for. And, again, private payers usually follow, but there's no guarantee with that, right? And so I think as this echoes, as this system evolves, right, we're going to see a lot of different iterations and changes. And so, at some point, a big player is going to make a move, right, and say, this is what we're going to do, and then everyone else will follow. But, it's kind of it's really hard to predict, right, because, if you can't truly successfully start providing this sort of telehealth services across the country, and you're really more localized, the dynamic changes a little bit, right? And so you don't have to think about that from a U.S. perspective. Your local private payers can think about it from a local perspective. And so, so I think, it's definitely evolving, and no one really knows what this is going to end up. But look, I think there's a lot of market pressure, right, with access and care. I think, and Nick can probably talk to this more than me, but I think there's a lot of studies out there that show that preventative care it works really well. And, you can see, a big, uptick in preventative care through this type of telehealth platforms, right? Both not only on the physical, but as you mentioned, Jenner, the mental, right? And, again, integrating, physical therapy, occupational therapy, having access to counselors, as part of this. And so I think when you start thinking about the well-being of the person holistically and moving forward, there's a lot of advantages to this. So I'm hoping it goes that direction, but it's unfortunately hard to tell at this point.
Yeah. One of the things that gives me hope here is Netflix, quite honestly, and not from a stuck in the pandemic and watching Netflix perspective, but if you think about healthcare as being analogous to Blockbuster in some senses, you had to actually go to a place to rent a movie, or you had to go to a place to access care. And then Netflix came along and literally started mailing people DVDs, right? You would get the envelopes in the mail, you would send them back, and it was really complicated, and it was actually kind of a mess. And perhaps that's where we are now, right? We're in kind of the mailing people DVDs section of the Netflix evolution. And I'm pretty confident that we can get to the point where it's just as easy as everything boils down to one remote and your TV. I think that's ultimately where we're headed in terms of thinking about how patients access care, being able to get it everywhere, and kind of having these offerings that really make things much more seamless and make things a lot better for the patient. So
can I just add one thing to that? And I think
absolutely,
this is the legal side of this, right? Which is privacy. Okay, so
Mhm.
I think previously, before we hit the digital age, people would think about their medical privacy in a way where they're like, okay, someone gets my health information, right? So they were more worried about insurance companies not cover them because now they know you got a pre-existing condition. This came up a lot in the genetic disease context, right? So there's a lot of state laws that deal really with insurance companies can't use this data to hold it against you. But that's all changed now. I mean, part of what happened during COVID was people were getting their identity stolen and filing fake disability claims, right? And then and so people who had no idea that they were on disability were having their information used to get checks from the government. And so I think as more people have access to this type of data, there's more potential bad uses for this stuff. And so it's great to integrate everything digitally and to have it all there, but the privacy side and the security side has to go hand in hand with this. And I think those things really have to make sure that they go step by step, because if you get too far ahead of that, I mean, look, there's like a couple 100 million people that got stuff stolen from, Target and these other big databases, and things get hacked all the time. And so, having your medical information out there is not quite like it used to be. Like, it can be used for a lot of different purposes now. And so, I think, talking about innovation and inventors, I think to any of the inventors out there, please be sure to think about privacy and cybersecurity as you develop this stuff, and creating, secure platforms or secure apps. So that way you don't have to worry about that on the back end when people start using it.
Yeah.
All
right.
Just to the point, currently even telephone can be used for telehealth with reimbursement, but certainly that has to stop, and I'm sure it will stop. So data privacy is critically important. So I totally.
And then Nick,
So
do you think that,
Go ahead,
one last question. Do you think that, and this is kind of bubbled up, can telehealth also be used to more efficiently bring patients in that need procedures, right? So that maybe we're not wasting time, but not spending time seeing patients that don't need an actual procedure, and narrowing down the ones that should be in the clinic or in the hospital?
Yeah, most definitely. So we can screen patients, and actually, we are developing certain criteria so that we can even sort of a way to figure out who has to actually come in with certain procedure, who should do the procedure, how complicated it is going to be, so that we can make sure that this can even be done locally, so they don't have to travel 3 hours, or they ought to come here. So I think that triaging process will add to the efficient use of resources. Yes, most definitely, Jennifer.
Okay, well, we're basically right at the end of our time. I want to thank both of you for joining us. I think this has been one of, really one of the biggest forces to come out of the past year is how we've interacted with each other, and certainly how we've interacted with the healthcare system. And like both of you had said, we're now in this middle area, right? We're not out of the woods legally, and we don't have it perfect from a care perspective, but I think we're getting there. And I think the nice thing here is that everyone realizes that there's a new way that we can access care that I think can be more equitable, certainly more appropriate for a wide swath of people, and hopefully we get better patient outcomes, better patient health, and and our system functions in a way that it really should be. So again, thank you both so much for being here. Thanks to Moses and Singer for sponsoring the series. We truly appreciate it. Thanks. Have a wonderful day, everybody.
Thanks, everybody.
Bye-bye.
Thank you very
All
much.
right, we'll see you next week.
Thank you for tuning in to NewYorkBIO's virtual breakfast series. Join us every Tuesday at 9 a.m. for more discussions with leaders from across the healthcare spectrum. For more information on NewYorkBIO, please visit us at www.newyorkbio.org.